طيب بسم الله we are live on YouTube. بسم الله دكتور تفضل.
Greetings to all our audience from different parts of the world. Today we are honored to hosting you in our first International Saudi German Hospital Stroke Symposium, and we are honored to host outstanding pioneers in the field of stroke medicine who achieve great success in that field regarding patient care and also continuous medical education. Today we have Professor Dr. Hani Arif, Head of Neurology Department at Ain Shams University and Director of Stroke Program, and Professor Dr. Majid Al-Luqmani, Professor of Neurology at Taiba University and holding Canadian Board of Neurology and Consultant Neurologist at Saudi German Hospital, Madinah. And we have Professor Dr. Ahmed Al-Basyouni, Professor of Neurology and Neurovascular Intervention at Faculty of Medicine, Ain Shams University. Today, we are going through interesting journey dealing with various aspects of important stroke topics regarding transient ischemic attacks, updates in management, and small vessel disease management, and endovascular intervention in stroke management. For our audience, if anyone wants to ask a question, he can hit icon of question and answer. And at the end of our 3 sessions, we will start a discussion of the questions with our speakers. We will start with Professor Dr. Majid Al-Luqmani regarding updates in transient ischemic attack. Dr. Majid, you can start. Dr. Majid?
Hello?
You can start sharing your topic.
Okay, is it I shared my topic. Is it clear now? Can you see it? Hello, can you hear me, Dr. Mohammed?
Yes, I hear you, but till now this the topic not appearing in front of me on the screen.
Okay. Okay. Can you see it now?
Yes, it is clear now. You can make it full screen.
Is it full screen now?
Yes, I see it. Could you make it full screen, please?
It's full screen now for me.
No, not yet. Yes, it's okay, Dr. Majid. You can start. Yes. For us, the same. You can start.
Okay. Hello and good evening, everyone. Thanks for the organizer, for Dr. Mohammed Fuad for this introduction. Thanks for having me today with you. I'm very glad and happy to give me this opportunity to be with you today and with other colleagues from different parts in the world to share our expertise in the field of stroke. So today I'm going to talk about transient ischemic attack. This is my objectives for the talk today. I'm going to run over the definition of the TIA, prognosis of the TIA, etiology of the TIA, and how we can stratification and evaluation of the patient with the TIA. Also, I'm going to run over a management of TIA. So the clinical definition of TIA based on a focal neurological sign or symptoms referable to non-cerebral arterial distribution without direct measurement of blood flow or cerebral infarction. However, when we see this clinical definition, there is some missing part. As a neurologist or our subconscious, when we hear transient ischemic attack, we are always focused on a time. So the historical time-based definition of TIA was based on full resolution of all symptoms within 24 hours of onset. However, in 2002, after a retrospective study they find that up to 50% of patients fulfilling the time-based definition of TIA, which is resolution of all symptoms within 24 hours of onset, they demonstrating that a focal lesion in DWI MRI. So based on that observation, a group of cerebrovascular physicians proposed a tissue-based rather than time-based definition in 2002. And they come up with a new definition, which is brief episode of neurological dysfunction caused by focal brain or retinal ischemia with clinical symptoms typically lasting less than 1 hour and without evidence of acute infarction. Later on, they revised the definition of transient ischemic attack to a transient episode of a neurological dysfunction caused by focal brain, spinal cord, or retinal ischemia without acute infarction. As we can see, they take off the time-based definition. So do you agree with that? Don't agree with that? It's a debatable point, but there is some point in favor of the new definition. So the classical 24-hour definition was misleading in that many patients with transient episode less than 24 hours actually have a cerebral infarction, as I mentioned earlier in the retrospective study. Also, the traditional definition can embed or delay the administration of the acute stroke therapy if the patient lasts more than 6 or 8 hours, and you assuming that he's a TIA, so a patient will lose his opportunity to receive the acute stroke therapies. So talking about prognosis of transient ischemic attack, about 1 in 10 patients with TIA experience stroke in the next 3 months, with half occurring within the next 48 hours. In one series, in a patient who subsequently experienced stroke, so basically in this series, patient who presented with TIA and subsequently they experienced stroke, they find that 21% of them do so within 1 month. 3 months stroke risk was about 10.5%. Furthermore, 50% of those stroke occurred within 48 hours of TIA onset. 5 to 6% annual mortality rate after TIA is mainly caused by MI. So not only a stroke could be the risk or the complement of the TIA, also cardiac event could be elevated after the TIA. So in a large study, 2.6% of TIA patients were hospitalized for a major cardiovascular event, myocardial infarction, unstable angina, or ventricular arrhythmia within 90 days. Also, over the course of 5 years, a nearly equal number of patients with TIA will have myocardial infarction or sudden cardiac death, as well as having a cerebral infarction. Cardiac events are the principal cause of death in patients who have had a TIA. Etiology-wise, 25 to 50% related to atherothrombotic infarct, up to 30% could be cardioembolic infarct, up to 14% could be a lacunar infarct. So in order to certification and evaluation the patient, we use the EBCD2 score. It's composed of age, blood pressure, clinical feature, and TIA duration and diabetes. In combined validation cohort, the 2-day risk of stroke was calculated as 0 for score 0 to 1, 1.3% for 2 to 3, 4 for 4 or 5, and 8 for score 6 or 7. However, as a neurologist, we like to do a brain imaging. So shall we include the imaging in the stratification? Yes. So the evidence of acute infarction on non-contrast CT alone has been shown to be predictive of recurrent stroke in patients with TIA, although the proportion of patients with evidence of acute infarction was small, was 4%, because of the timing of the CT. CT angio provide much more information than a non-contrast CT alone, with imaging of the intracranial and extracranial vessels, evidence of 50% or greater stenosis or occlusion in a symptoms-relevant vessel in the intracranial or extracranial circulation, put a patient at high risk of a recurrent stroke. So imaging is important part of evaluation of TIA symptoms. MRI is more sensitive than standard CT. for both new and pre-existing ischemic lesion in TIA patient. DWI sequence provide more precise evaluation for ischemic insult in TIA patient. Up to 50% of patients clinically diagnosed with the TIA using a time-based definition have evidence of restricted diffusion on acute MRI scan, as I mentioned earlier. Most studies of recurrent stroke after TIA have shown an increased risk of short-term recurrent stroke in the presence of a lesion seen on DWI. In a multi-center patient-level analysis of 800 patients, in which DWI lesions were present in 33% of TIA patients, the predictor for DWI positivity were presence of motor symptoms, longer duration of TIA, MRI within 24 hours of resolution of symptoms. So after doing imaging for brain, imaging for extracranial vessel also, it's reasonable. So carotid ultrasound, transcranial Doppler, MRA angiography, CTA angiography. For carotid ultrasound, detect about more than 50% stenosis of the extracranial internal carotid artery, up to 31% of patients with TIA and very minor stroke. Carotid ultrasound also provide reliable assessment of the carotid bifurcation. The sensitivity of the carotid ultrasound is ranging between 88 and the specificity is around 76 which has been reported. MRA sensitivity is around 92%, specificity around 76% for extracranial carotid disease. CTA, it's about 100% negative predictive value for excluding more than 70% stenosis compared with catheter angio. So it's a good screening test. For the intracranial vessel imaging, using TCD, it's a good thing. So it has a positive predictive value around 36% and negative predictive value around 86%. MRA and CTA had a comparable performance for identification intracranial stenosis. Cardiac testing is an important thing to do in a TIA patient. So doing ECG, transthoracic echo, and transesophageal echo as well, Holter monitor. TE is more sensitive than transthoracic echo for atheroma of the aortic arch and abnormalities of the intra-arterial symptoms like PFO, arterial septal aneurysm, and ASD, also atrial thrombus and valvular disease. So now I'm going to talk about the management of TIA. So recognition and management of TIA offer a greatest opportunity to prevent disabling stroke. Studies have shown up to 80% reduction in the risk of stroke after TIA with the early implementation of secondary stroke prevention strategy, including revascularization of patients with symptomatic carotid artery stenosis, anticoagulation of patients with atrial fibrillation, treatment with antiplatelet, treatment with statin, management of hypertension, diabetes, and dyslipidemia. For carotid disease, I'm not gonna talk in detail about it. I'm gonna leave it to my colleagues later on, but just a few lines about it. Early carotid revascularization for patients with 50% or greater symptomatic carotid artery stenosis is an effective form of stroke prevention when performed within the first 2 weeks after an event. It's important to identify carotid stenosis because it causes 10% of all TIA patients. It causes 50% of early recurrence. In terms of intracranial atherosclerosis, for patients with recent stroke or a TIA within 30 days, the patient whom having severe stenosis ranging between 70 to 99% of a major intracranial arteries, the addition of clopidogrel 75 milligram to aspirin for 90 days might be reasonable, and also maintain a blood pressure systolic below 140, and also maintain the LDL by starting statin are recommended. For patients with stroke or TIA attributed to moderate stenosis ranging between 50 to 69% of a major intracranial artery stenosis, the angioplasty or stenting is not recommended. given the low rate of stroke on medical management and the inherent of pre-procedure risk of endovascular treatment. So the risk of procedure is more than the benefit. So the stenting is less favorable than the medical management for these patients. If the patient has intracranial stenosis, so there's a study, we call it Symposium, which basically they compare the stenting versus aggressive medical management in people with intracranial stenosis. The study results show that aggressive medical management alone was superior to stenting in the prevention of recurrent stroke. The medical management include 325 milligram aspirin and 75 milligram clopidogrel for 90 days, together with intensive medical management of modifiable vascular risk factor. Antiplatelet. All patients with TIA should be an antiplatelet agent, except for those who are being anticoagulant for atrial fibrillation. For most patients, it will be a single antiplatelet agent, usually aspirin monotherapy. Other options include 75 milligram clopidogrel or a combination of aspirin and dimipridol twice a day. Dual antiplatelet. There has been 2 randomized clinical trials. They study the dual antiplatelet. The first one, FASTER, which basically they compare 3 months of treatment with 81 milligram aspirin and 75 milligram clopidogrel within 24 hours of onset versus aspirin alone in patient with a minor stroke. So the trial was small and ended early, but it showed that a combination therapy may reduce a recurrent stroke event with a low risk of complication. The second and the largest trial was CHANCE, which basically randomized, and they recruit around 5,000 patients. And they test also the dual, the clopidogrel plus aspirin versus aspirin alone. So in this study, the recurrent stroke was seen 8.2% of patients in clopidogrel aspirin group compared to 11.7% of this aspirin group. And the risk of the hemorrhage was not different in the 2 groups. So we can see from these 2 study, the dual antiplatelet is good. But the first study, it was for 90 days, and the second study was for 21 days. So now dual antiplatelet, but now for how long, what is the duration? So now they come the point study. So the point study, she wants to know what is the best duration for the dual antiplatelet. And basically the results show that combination of the clopidogrel and aspirin had a lower risk of major ischemic event, but a higher risk of major hemorrhage at 90 days. So these studies show that 90 days on dual antiplatelet, the risk of hemorrhage is more than of the patient in dual antiplatelet for 21 days. So based on this study, maybe it's good to leave your patient up to 21, up to max 1 month for dual antiplatelet. So also this study, the TARDIS study, so they test the triple agent. So in this study, they combined aspirin, clopidogrel, and dimipridol versus either dual antiplatelet, aspirin, and dimipridol, or a 1-agent clopidogrel alone. So the conclusion was the use of 3 antiplatelet agent is associated with increased bleeding without any significant reduction in recurrent of stroke or TIA. So up to 40, it's basically the study, it's showing various studies, showing various percentage, but between 5 to 44% of people, they might have clopidogrel resistance. And this is because of the gene polymorphism CYP2619 associated with clopidogrel resistance result. That's if the patient had this gene, so he will not be able to convert clopidogrel to its active form in the GI tract. So for this patient, ticagrelor is a good substitute. So it's a B2Y12 receptor antagonist. It's unlike clopidogrel, it's orally active without the need for metabolic activation. Also, one advantage of ticagrelor is over the clopidogrel include faster onset and more consistent platelet inhibition. So they studied the ticagrelor in the SCORATE trial. So it was superior to the aspirin in reducing the ischemic stroke, and there was no significant difference in the rate of major bleeding. In a subgroups, Ticagrelor was superior to aspirin at preventing stroke and MI or death at 90 days in patient with ipsilateral atherosclerotic stenosis. This is another agent with the same mechanism of ticagrelor. Its study against the clopidogrel, it was non-inferior to that. It was equivalent. So just a few slide about to manage the hypertension. So it's basically treating hypertension is important in TIA patients. So it's indicated for previously untreated patient with ischemic stroke or TIA after the first several days, and in patient whom established blood pressure more than 140 and systolic and diastolic more than 90. So initiation of the therapy for patient less than, if the blood pressure less than 140 and the diastolic less than 90, it's uncertain benefit. But again, so this usually is dealt by medical people. So I think it's good to follow the guidelines to start the antihypertensive medication if the patient having a high blood pressure more than 140 systolic or more than 190 systolic. The dyslipidemia, statin therapy with intensive lipid lowering effect is recommended to reduce risk of stroke and cardiovascular event among patients with ischemic stroke or TIA, presumed to be atherosclerotic origin, and if the LDL more than 100 milligram per DCL. In terms of glucose disorder, after a TIA or ischemic stroke, all patients should be screened for diabetes with testing either fasting blood glucose or hemoglobin A1C or an oral glucose tolerance test. In general, hemoglobin A1C may be more accurate than other screening tests in the immediate post-event period. So just to wrap up, so my conclusion for my talk, the tissue-based definition of TIA, transient episode of neurological dysfunction caused by focal brain, spinal cord, or retinal ischemia without acute infarction may be the reasonable definition for TIA. Patients with TIA are at high risk of early stroke, and the risk may be stratified by clinical scale, vessel imaging, and diffusion MRI. Diagnostic recommendation include for TIA patients should undergo neuroimaging evaluation within 24 hours of symptom onset, preferred to be an MRI with DWI sequence. A non-invasive imaging of the cervical vessel should be performed. Non-invasive imaging of the intracranial vessel is reasonable. ECG should be done as soon as possible after a TIA, and prolonged cardiac monitor and echocardiograph are reasonable in patients in whom the vascular etiology is not yet identified. Routine blood test also is a reasonable thing. It is reasonable to hospitalize patients with TIA if they present within 72 hours and having an ABCD2 score more than 3, which gave me an idea this is a high risk early recurrence patient, or the evaluation cannot be rapidly completed on the outpatient basis. Thank you, and I'm happy to have any question now or after we finish the panelist. Thanks.
Thanks a lot, Dr. Majid, for that full dose updated information about transient ischemic attack. It was really touching our daily clinical practice. And for our audience, anyone want to ask a question for Dr. Majid, they just put the question in question answer icon, and at the end of our talks, we will discuss it with our speakers. Now I am moving to Professor Dr. Hani Arif, who will give us a very interesting topic about small vessel disease, which considers like slowly growing huge monster, which is underestimated and underrated in our daily clinical practice, but really it is highly prevalent among patients, especially if screened for small vessel disease. And we have defect in our clinical practice regarding patients of small vessel disease, regarding its long-term impact on his daily life activity and functional outcome. Now, Dr. Hani, you can start with your presentation, and we are hearing you.
Thank you, Dr. Mohammed, very much for the invitation, and I would like to thank also the Saudi German hospitals for arranging this series of webinars, which are very important to share the experience and also to convey the knowledge to our colleagues and students. I will take you through a journey of the history and the evolution of the small vessel disease and how far now we can it and manage it, because it's a really interesting story from the very beginning. I will go through the definition, the pathophysiology and risk factors, the clinical presentations, the markers of the small vessel disease, and how to manage. Arbitrarily, the small vessel are defined as brain intraparenchymal vessels, including perforating arteries derived from the circle of Willis and small veins, and also the leptomeningeal small arteries. But when we are talking about small vessel disease, in fact, we usually mean predominantly the arterioles and the small arteries penetrating the brain. And this is the Indian injection showing the penetrating intraparenchymal vessels. In general, we are talking about small arteries or arterioles in the range between 40 and 400 micron. The story started in the 60s with Miller-Fisher. Miller defined a term called the Lacunar Infarctions. And by lacunar, he meant at that time an ischemic infarct of restricted size, less than 15 millimeter. And we should consider that at that time there was no CT MRI. So he defined the clinical presentation based on the autopsy study and histopathological studies that was done at that time. And later, many, of course, pathological studies were done and showed that these arterioles were showing different pathologies, including lipohyalinosis, microaneurysm, microatheroma, fibrinoid necrosis, these small arterioles. But before going to the TOST classification, we should remember that this was not very correct, because we based a clinical presentation on a histopathological subtype, which is not always is the case, because sometimes you can have the same clinical presentation which is not due to lacunar syndrome. And also lacunar syndrome can cause a clinical presentation which is not necessarily the described types by Fisher, and this problem is still holding till now. Now we'll come to another problem. Actually, this was because of the TOST classification. TOST was originally a study done almost 20 years ago, and it was for the study of the low molecular weight heparin in treatment of stroke. Despite that the study failed, but what remained is the classification of stroke, which is still widely used. Of course, everybody knows that we are classifying stroke according to the TOST into etiological classification into a large artery atherosclerosis, cardioembolism, small vessel occlusion, stroke of other determined etiology, and stroke of undetermined etiology. If we come to the small vessel disease according to the TOST, it's meant the clinical signs of a lacunar syndrome according to the originally described types by Fisher, and radiologically, because now we are not doing autopsy, of course, anymore, so CT or MRI showing lacunar infarction of a size less than 1.5 millimeter. And again, there will be a problem because, as I've just mentioned, sometimes you can have the same clinical presentation, but it's not related to a small-sized infarction. And also, you can have a lacunar syndrome radiologically, but it might be of a cardioembolic origin, and this was proven in many literature. And that will show, this shows you that the matter is quite complicated. In general, The small artery disease will represent about 25% of the different types of ischemic strokes. But actually in Egypt, we did a study just a couple of years ago, and we found that the incidence of small vessel disease is quite higher, especially in the urban areas like Cairo. It was 34%. Now we'll come to another dilemma, because small vessel disease will not necessarily present by acute infarction. Sometimes we can have a silent lacunar infarction, or even a white matter hyperintensity, which might present by other neurological manifestations. And this is gaining more and more importance in the last years. It's expected that 40 million people currently having dementia, and this number is predicted to double, and the vascular component of these types of dementia is largely contributed to this small vessel disease. So if we can see the different presentations of the different types of vascular affection, we can see very importantly, the silent small vessel disease with lacunes or with white matter hyperintensity, and can present with dementia, with incontinence, with gait disturbance, with cognitive impairment, with depression. So in general, the clinical manifestations of the what's called in between brackets covered or incidental small vessel disease, the patient can present insidiously with gait abnormality, with cognitive decline, with sphincteric disturbance, and even he's not having any vascular event, acute vascular stroke. This led a group from Scotland headed by Joanna Wardlow. She's a queen of small vessel disease and studies, and to put forward the criteria, which is called STRIVE criteria, trying to standardize the imaging of the small vessel disease. But why we need standardization, and especially with the MRI? Because MRI has become imaging standard in most of the researches, and also there is advances in the acquisition and different processing techniques, and also we need to harmonize the imaging and the different protocols to facilitate pooling of data and to do meta-analysis and to do comparison for different studies, and we need to unify the language we are talking about, especially that there is a growing appreciation of the impact of the vascular factors in neurodegeneration, as I've just mentioned, in dementia and also in other neurological disorders. Just an example of the nomenclature used in the literature for the presumed vascular hyperintensity, the presumed white matter hyperintensity of vascular origin. You can find different terminologies like leukoariosis, white matter lesions, white matter hyperintensities, white matter changes, leukoencephalopathy, white matter disease, and so on. So we need to unify all these terminology. According to this STRIVE, they classified the small vessel disease on neuroimaging into 6 subtypes: recent infarction, white matter hyperintensity, lacunes, perivascular spaces, microbleeds, and microinfarcts. And these are the 6 subtypes. The recent infarctions, smaller in size, less than 20 millimeter in diffusion or 15 millimeter in flare. White matter hyperintensity, lacunes, the perivascular spaces, the microbleed, the microinfarcts. I will go rapidly through each type. We will start with a small subcortical infarction of a size, as I just said, 20 millimeter in diffusion or 15 millimeter in flare. The 10% will disappear. 70 to 80% will turn into white matter hyperintensity and not lacunes, and only 15 to 20% will turn into a small lacunes. And this is the fate of the small infarctions. Even sometimes a large infarction will turn out into a white matter hyperintensity or into a lacunes, but this is quite uncommon. Now we'll come to the lacunes. Lacunes, as we can see, it's a cavitation in the brain of a size less than 15 millimeter. They are rounded or ovoid and between 3 millimeter, not less than 3 millimeters. This is very important, and not more than 15 millimeter in diameter, and not necessarily due to infarction, sometimes due to hemorrhage. And regarding the white matter hyperintensities, which are commonly seen incidentally in many of the imaging, especially in old age, of course, this can be of a vascular origin or a degenerative process. I will not go through how to differentiate between these shapes and areas, but at least suffice to mention here that we have the famous Fatzikis grading of this white matter hyperintensity into a grade 1, which is punctate lesions, and the grade 2 starting to be confluent, and grade 3, which is having a very confluent lesions in the brain. Martin Dechans and his group actually described very elegantly the relation between the lacunes and white matter hyperintensities in this paper published in Brain, and they showed that usually the lacunes will just touch the edge of the white matter hyperintensity, and most of the cases they will go through this white matter hyperintensity. Rarely they will go away, or they can have any pattern in relation, but this is uncommon. But most of the pattern, they will go through the white matter hyperintensity. The perivascular spaces, which are dilated spaces around the small blood vessels, the penetrating arteries, and the most important thing, they are smaller than 3 millimeters, because if they are larger than 3 millimeters, then probably this is lacunar spaces, lacunar infarctions, and they will appear linear if the imaging is perpendicular to the vessel, and if it's if it's parallel to the vessel. And if it is perpendicular to the vessel, they will appear rounded with a size less than 3 millimeter, as I just mentioned. And this is a pathological pattern of these very dilated perivascular spaces. They used to be also called in the old literature status cribrosis or ete cribly. The cerebral microbleeds, they are small, generally 2 to 5 millimeter, but sometimes up to 10 millimeters area of single signal void, usually very apparent in the T2 star weighted imaging, or sometimes, of course, also it's even more apparent in the susceptibility weighted images. They can be central, and this is usually associated with the classic small vessel disease, or peripheral, especially with the cerebral amyloidosis. Brain atrophy, of course, it can be correlated to the white matter hyperintensity. Commonly with the extensive white matter hyperintensity, we can see shrinkage of the brain with brain atrophy, which is considered also entity of the small vessel disease. And lastly, the sixth pattern is the microinfarcts, which are small infarcts occurring in the cortex, and they are very difficult actually to be seen in the regular commonly used MRI 1.5 Tesla, and even on the 3 Tesla, it's uncommon to be seen, and needs to be high resolution imaging and thin cuts. And probably they are very evident on the 7 Tesla, which is not, of course, in common practice. And still, the etiology is not very definite, whether this is due to definitely occlusion of a blood vessel also. Stahl et al. Proposed a score for the small vessel disease. So they call it total small vessel disease score, based on these 4 patterns, imaging patterns: the lacunes, the microbleeds, the perivascular space, the white matter hyperintensity. And instead of using only any of them, like white matter hyperintensity based on the Fitzsimmons scale, which is commonly used, Now I will come to the pathophysiology of the small vessel disease. It results from a chronic ischemia in the perforating arteries supplying the brain, especially the white matter. And it results in both lacunar infarction and chronic ischemia leading to leukoariosis. The two proposed mechanisms, the chronic hypoperfusion will lead to a chronic ischemia resulting in these white matter changes, and also an important mechanism, which is the increased blood-brain barrier permeability with leakage of plasma component into the vessel wall surrounding the brain. Probably the inflammatory process will play a major role in this aspect, whether it's due to a chronic inflammatory state contributing to this, or due to some of the, now there is what's called a chronic inflammatory state due to many reasons like obesity even, or the presence of a septic focus in the body, or a chronic inflammatory process in the teeth, and so on. All these probably can invite an increase in the brain permeability and can invite the affection of the blood-brain barrier. So the vascular component, I like this slide very much because it shows that many of the diseases we considered as purely degenerative, or sometimes like Alzheimer's disease, or sometimes purely inflammatory like MS, definitely they have a vascular component. So it seemed that inflammation, the vascular component, and the neurodegeneration, all three are playing together for the different pathologies in our neurological disorders. The dementia, of course, is a classic type. We used to think that Alzheimer's disease is not related to the vascular dementia, and now definitely there is a spectrum between the Alzheimer's disease and the vascular dementia, and most of the cases will lie in between, depending on the vascular component and the neurodegenerative component. So the white matter changes is always a player in many of our neurological disorders. And there is more and more stress on the break, as I've just mentioned, of the blood-brain barrier, which can be responsible for the lacunar stroke, the leukoariosis, and the dementia, and probably other disorders as well. And this was important study. Actually, the latest trial started more than almost 20 years ago, and still going on, studying the causes of repeated falls due to the affection of the brain. And they studied the effect of the small vessel disease across time. And in this study, they showed that over years, there is a progression, a silent progression of the small vessel disease, which can present with the repeated falls and gait problems. So it's more or less a silent, I will not say a silent killer, but a silent disabling disorders, which should be considered and should be noticed, and even should be followed sometimes with follow-up MRI and repeated MRI, and controlling, of course, the risk factors which will contribute to this white matter changes. Now, regarding the biomarkers, if there is any biomarkers for the small vessel disease, of course, we all know the risk factors of stroke, and we can see if the patient is having diabetes, hypertension, and so on, probably is more liable to develop a stroke. The same also is true for a small vessel disease, but there is anything specific. Maybe people are trying also to use the eye examination, especially after the advancing techniques with the OCT and other modalities, the radiological, and of course, the laboratory. Regarding the fundus examination with detailed visualization of the eyes, there is some trials and some studies trying to utilize this, like this study, which is studying the small vessels, considering that these are the window to the blood vessels and the small vessels of the brain. And they are trying to measure exactly the small vessels of the retina, so they can correlate this with the small vessels inside the brain. And now also with more advanced technique like the OCT angio. But still, the most important, as I've just mentioned, the radiology. whether it's the load of the T2 white matter hyperintensity, the lacunar infarcts, and the 6 types I've just mentioned, the microbleeds. But there is also important point regarding the CSF leak. We can do contrast with the flare. So if there is a leak, this means there is increased permeability of the blood-brain barrier, and probably this is a marker also for the inflammatory process, which is contributing to the small vessel disease, and of course the brain atrophy and the cortical thickness. This is the susceptibility weighted image and T2 star. We can see that susceptibility weighted image is visualizing the microbleed very evidently. And this is the leaking blood-brain barrier in MRI as a technique. This is the routine. This is the T1. We cannot see much of the contrast, but if we do it with the flare, we can see there is a leak in the meninges, suggestive there is a break in the blood, diffuse break in the blood-brain barrier. Also trying to search for markers, even very simple marker like the C-reactive protein, the D-dimers, the interleukins, the ICAM, the plasma beta amyloid. All these can help and can contribute in having a biomarker for the small vessel disease. Now I will come to the management of small vessel disease. Is there anything specific for the small vessel disease? Unfortunately, there is no specific management for small vessel disease apart from the prevention, the control of the risk factors. But there is some literature supporting the use of silistazole, especially because of its pleiotropic effect on the blood vessels. So maybe we can utilize silistazole in the small vessel disease as an antiplatelet. But the most important thing, as I've just mentioned, is the tight control of all risk factors. They are no difference in different studies between the risk factors of small vessel disease and large vessel disease. Maybe the homocystinemia can contribute more to a small vessel disease. And probably in the future, I guess the inflammation, the inflammatory markers, especially the control of chronic inflammatory process by any means, this is important, also controlling the small vessel disease. But when we will come to the basics, we know, of course, is the simple 7. The simple 7 is the best way to prevent any stroke, whether it's small vessel disease or large vessel disease. So never to smoke, the body mass index less than 25, doing the physical activity with the specific protocol, and the healthy food. The total cholesterol should be less than 200 and the LDL less than 70, and the blood pressure should be below 120/80, and the fasting blood glucose less than 100 milligram per DL, and the glycosylated hemoglobin less than 7 for diabetics. So if people stick to these simple 7s, they will have a very good chance of not developing stroke, whether a small vessel disease or large vessel disease. And this was, despite they are simple, but it's very difficult to be achieved. And this was proven in the Northern Manhattan study when they showed in 20,000 people, nobody stick to this simple 7, and only 15% of women and 20% of men, they could achieve 4 or more. So it's very important now to talk about the brain health. You remember the 3 trees, the vascular, the inflammation, the neurodegeneration. So if we can stick to the brain health, probably we can minimize the effect of these 3 processes: the inflammation, the neurodegeneration, and the vascular component. With many factors can be achieved by trying to combat all these factors which will affect the brain health. Of course, many factors are difficult to control, like the genetic component, but probably now we are hearing about the gene therapy and even how to affect the genes affecting the cholesterol level and the LDL level. I guess in the future, also the genetic component will contribute to improving the brain health. Everybody's working on this. Of course, what's concerned with the small vessel disease, how to combat the white matter hyperintensity, the silent brain infarcts, and the brain atrophy. All these factors, if we followed them thoroughly and if we try to improve the lifestyle, the different risk factors to improve all these things, I guess we can have a good prevention of the small vessel disease and the stroke in general. So to conclude, small vessel disease definition actually is still debatable, and there is many problems regarding the definition, as I've just explained. There is a need for recent classification. STRIVE is a good start, but we need also more and more elaboration for clinical classification. And small vessel disease can be caused either by occlusion with a classic lacunar syndrome or a chronic hypoperfusion resulting in local areosis presenting with cognitive decline, executive dysfunction, gait disturbance, urinary incontinence, and depression. Endothelial dysfunction plays an important role in the pathogenesis and may be the main player causing leak in blood-brain barrier. Laboratory and radiological marker can be used to diagnose small vessel disease. Small vessel disease can be at least partly preventable as part of improving brain health, which is very important nowadays. And thank you.
Thank you so much, dear Professor Dr. Hani, for that outstanding and unique presentation about the hot topic regarding small vessel disease. And we expect from you as a leader, as we are adapted with you, to have more and more focus regarding that area, regarding research and continuous medical education. Dr. Hani, for our audience, Dr. Hani is a leader of stroke, not just a scientist, but a leader. As he started on his shoulder with a group of universities in Egypt to start the plan of stroke care, and also developed this to the Middle East regarding MENASO, and also forming stroke teams. That stroke teams go through many new faculties of medicine in Egypt, and also take the scientific research regarding stroke medicine in Egypt into another area, and did a lot of scientific activities regarding Egyptian Society of Neurology, Neurosurgery, and Neuropsychiatry. Thanks a lot, our dear professor. And now we are moving to Professor Dr. Ahmed Al-Basyouni. As we said about Dr. Hani regarding the field of stroke as general, Dr. Ahmed Al-Basyouni is outstanding professor of neurology, neurovascular intervention. That field 10 years before in Egypt, it was not well formed regarding teams for endovascular intervention. Dr. Ahmed Al-Basyouni has a set for next generations for neurovascular interventionists, and goes through many stroke teams, not only Ain Shams University, but many universities, especially in Upper Egypt and the new universities and general hospitals regarding stroke unit establishing in the program of Dr. Hani Arif, and also health insurance hospital. We can find now a lot of generation in the field of endovascular intervention. This is in favor of the great effort established by Egyptian society and Professor Dr. Hani vision, and also Dr. Ahmed Al-Basyouni, his scientific trips to the different areas. Now we are going through a journey regarding endovascular intervention of acute ischemic stroke. Dr. Ahmed, you can start.
Thank you, Dr. Muhammad, for the invitations. Thank you for the Saudi German Hospital for the invitation. I'm trying to share my screen. I don't know if it's obvious now or not. Can you see it, Dr. Muhammad?
Till now, not obvious to us. Take your time, we are waiting you. Mr. Ali,
السلام عليكم. دكتور أحمد, you can send it to me and I will share it. السلام عليكم. معلش نعتذر عن هذا الخلل. إن شاء الله خلال دقائق إن شاء الله نحل المشكلة إن شاء الله.
Sorry for our audience for that technical obstacles. So we can take your questions for Professor Dr. Majid Al-Lukmani and Professor Dr. Hani Arif until we solve that technical problem. So if anyone wants to ask a question, he can put his questions in question and answer icon, and we will discuss it for them. Dr. Majid, you hear me?
Dr. Mohammed?
Yes, Dr. Majid, we have a question for you from Karim Abdo. Patient not known to have hypertension presented with transient ischemic attack after complete resolution of his symptoms with blood pressure about 180/90. Is it reasonable to decrease his blood pressure?
So yes, you mean according to the study, as I mentioned earlier, if the patient has high blood pressure, systolic more than 140, systolic more than 80, yes, it's preferable to decrease blood pressure, but not in the early.
So we have also another question about reducing. Yes, I hear you well. We have also another question regarding reducing blood pressure during acute attack. Previously, we know not more about 25% of mean arterial blood pressure, but you mentioned in your talk that it is 140.
Can you say it again? I didn't hear you. So the voice, it's go back and forth. I can't hear you.
We have a question from Dr. Al-Tayyib. He said that before we hear to reduce blood pressure during acute attack, not more than 25%. But you mentioned in your talk that it is 140. You need illustration.
So yes, so as I mentioned in the first questions, so during the acute phase, for the first 24 hours, we did not usually tend to decrease the blood pressure. So usually later on, we tend to decrease it 15 to 20% in the next 48 hours. But acutely, we don't tend to decrease it initially. So I hope this is clear now.
Yes, this is clear. We have a question for our Professor Dr. Hani Arif. You mentioned that regarding pathogenesis of small vessel disease, we have microbleeds. Can that microbleeds being relative contraindication to patient receiving thrombolytic therapy, or it may affect the functional outcome after thrombolytic therapy?
According to the recent guidelines by the American Heart Association, American Stroke Association, if the number of microbleeds is more than 10, it might be risky. But less than 10, it's not risky, it's safe, and you can go for thrombolysis, no problem.
But if so, should we do MRI on the expense of time as time is brain?
No. This is not. I mean, part of the routine preparation of the patient. But sometimes, you know, some of the patients will have old MRI, or even for different reasons, they might start with the MRI. So if you counted the number of microbleeds and you will find them more than 10, you should weigh the risk versus benefit. But if less than 10, there is no problem.
And another question regarding the small vessel disease: is there a specific correlation between gait and small vessel disease significantly, or just a part of vascular dementia and gait is a part of it?
No, definitely there is a very strong link. This is the small vessel disease is. I like it as a story because it's if you remember the Binswanger disease, they used to call it lower body Parkinsonism. And actually it was proven that this is apraxia of gait because of the dysfunction and disconnection of the gait circuits, especially in the connection in front of the anterior horn of the lateral ventricle. Which is commonly affected in the white matter lesions and the capping, which is occurring in this area. That's why it's commonly affecting the mobility. And this apraxia of gait is responsible, of course, falls. That's the neuro, because, you know, because of these repeated falls, a lot of patients were admitted for hip fractures and to the nursing home, which is having a huge burden on the community. That's why they started, why those people are falling, and is it correlated to the small vessel disease and white matter changes? And since they started actually, since these 20 years to study more and more small vessel disease extensively. So it's one of the core features of the small vessel disease, the gait problems, the cognition, which is predominantly executive dysfunction, and the incontinence fury.
Okay, thank you, Dr. Hani. Another question, will patients who suffer extensive small vessel disease or have vascular dementia, that patient may benefit from anticholinergics like memantine, donepezil, or just prevent the progression only regarding antiplatelets?
Unfortunately, there is no approved indication for these drugs for vascular dementia, and even for the studies which were done initially, it wasn't effective, but you can raise some question mark about the design of these studies. But theoretically speaking and off-label, I guess I use them in vascular dementia and small vessel disease.
And what's your opinion regarding the future of genetic therapy based on the genetic background for patients who have small vessel disease? Will be it more applicable, or the prevention strategy is better than going that high cost kinds of therapy like we see in spinal muscular atrophy?
You know, the golden rule, of course, prevention is better than treatment. So it's if we stick to this, even the sample 7, I guess this will prevent, and this was proven in many studies, up to 80% of the occurrence of stroke, including small vessel disease. But in general, probably now, you know, of course, with the new drugs affecting especially the lipid profile, and even with the new genetic, I mean, there is a gene therapy now, you know, Novartis developed for the hyperlipidemia, which is taking every 6 months to keep the LDL below 50. They are claiming in their study that this will affect the vascular event. Of course, the primary endpoint was myocardial infarction MI, but also stroke was a second endpoint. I guess the number, it prevented the occurrence of stroke by 30% or more. So keeping a very low level of LDL, I guess this will be the future, and also maybe the chronic inflammation, which can have also a genetic background, because we all know that, for example, Cadacil disease is a classic example of the genetic small vessel disease. So probably if we can attack some of the genes which are responsible for the permeability of the brain and breakdown of the blood-brain barrier, this can be an important point.
Okay, thank you, Dr. Hani. We have a question to Dr. Majid Al-Luqmani regarding prevention of transient ischemic attack. If a patient who has recent transient ischemic attack and he is old age beyond 70, and as we see in guidelines, the high dose statin therapy, either 80 milligram atorvastatin or 20 milligram rosuvastatin, and that patient has history of myopathy regarding statin use. How can we adjust that problem? Should we stop it or lower the dose, and on which basis?
So for statin-induced myopathy, I mean, it's a clinical plus some laboratory markers. So CK should be high. If there is a correlation between starting statin and the symptom for the patient, yes, in this case, I will either go down or maybe change the same statin. So changing to statin or some other agent this patient. But first of all, I would like to make is there a correlation between the statin and the statin myopathy in this patient. So old age, they might have myopathy from different etiology. So making a link between them, yes, either I go down or maybe I change the different agent.
Okay, thank you, Dr. Magid. And we have another question regarding antiplatelets in transient ischemic attack. You mentioned in your presentation that ticagrelor has faster onset of action than clopidogrel, but till now we don't see use of ticagrelor in our clinical practice regarding stroke. Is it just under trials, or that trials find its way to clinical practice?
So yes, it's still, although some people, as I said, I mean, previously there was a patient who was resistant to clopidogrel, so we tried ticagrelor. So this is one. Our colleague in cardiology, they use it a lot nowadays, so they have a huge expertise with it. So, but in neurology field, is still not really fit in this. But in some certain condition, like clopidogrel resistance, sometimes we use it, but definitely is not the first agent to choice.
If you allow me, Dr. Muhammad, to add also a comment on this.
Yes, of course.
You know, there is recently the SALIS trial, which is contributing to the addition of the European Stroke ESO guidelines and also the American Stroke Association guidelines. We can use the dual antiplatelet ticagrelor plus aspirin for 1 month, especially in patient with risky TIA and minor stroke, and also most of the patients who benefit from this in the subgroup analysis of the SALIS study is the patient with the intracranial carotid stenosis more than 50%. Which is quite common actually in Egypt and I think also in our region. So probably ticagrelor will take a more role in the coming years in the management of risky patients.
So could we use it as acute treatment by high dose or just for preventive measure? Or no?
No. It's the primary endpoint is the occurrence of another vascular event, not improvement of the current stroke, but you know these patients are risky for especially recurrent TIA or patients with intracranial stenosis. They are quite risky to develop another stroke after the first one.
Okay. We have a question for you also, Dr. Hani, regarding silestazol in a small vessel disease. If that patient already have history of symptomatic stroke and plus his extensive small vessel disease, should we use silestazol superior to aspirin, or as that case we use aspirin superior to silestazol, or both?
You know, the problem with silestazol, it's originally a Japanese drug. It's not a Western drug. So probably it was for decades in the eastern side of the hemisphere, before even the approval of the Plavix in that region. And it's approved only for the peripheral vascular disease, I guess, in the States. But now it's coming more and more in the guidelines. We can use it either as a dual antiplatelet, or there is some reports, and I guess also some of the guidelines put it especially in small vessel disease, because you know the importance of the silistazole, it has what they call the pleiotropic effect. So it can actually affect the endothelial dysfunction and the release of different hazardous substances, cytokines, and so on, which can damage the small vessels and can damage the brain. So I think it will come more and more in the future, especially for a small vessel disease, either alone or in combination with aspirin.
What about, we have read a study about vascular endothelial cell adhesion molecule, and it was in Egypt, I think, did by Dr. Ayman Nasif, I think. Do you think that kind of study regarding that biomarkers will help in drawing a map for...
Sorry, I didn't hear you, the question.
Regarding vascular cell adhesive molecule, regarding vascular cell adhesive molecule, we have a study before, I think, by Dr. Ayman Nasif in Egyptian, regarding the functional outcome and prognostic marker for stroke patients. Is it could be applicable to all patients, and making a genetic map or a map of biomarkers for Egyptian patients or patients in the Middle East? And also we have previous study you shared before regarding characteristics of patients with a stroke in the Middle East. I think it was a big study. What do you think regarding applying this of a small vessel disease?
Actually, fortunately, just a few weeks ago, we had finally we had a grant. It's a good grant for studying small vessel disease, which will allow us to do a whole exome for patients with a small vessel disease in Egypt. And I think this can lead to better understanding of the genetic background of those patients, because I think it's quite common in Egypt and probably in our region, when you do MRI for patients coming for any reason, headache or whatever reason, not even having a vascular event before, to find these silent lacunes and white matter hyperintensities. So I think it's quite common. And if you dig deeply into those patients, you will find there is some kind of gait abnormalities and some kind of cognitive abnormalities. So I think there is definitely a genetic background for this. That's why we are going to make a good research regarding this aspect. Regarding silistazole, actually there is two current studies. You can go through them in the clinicaltrial.gov, the LACI-1 and LACI-2. They are studying the effect of silistazole on small vessel disease. And I guess one of the studies also is the principal investigator is also the Joanna Wardle. As I said, she's one of the most, if she is actually the most important person in studying the small vessel disease.
Thank you, Dr. Hani. We have a question also for Dr. Magid. You said, Dr. Magid, that about 50% of patients who are diagnosed as transient ischemic attack, already those patients, if they are well investigated regarding stroke, we will find them, they were already ischemic stroke, not transient ischemic attack, and you mentioned the criteria for it. So do you recommend doing advanced brain imaging later for any patients with transient ischemic attack, unlike the standard investigation regarding CT brain and carotid and vertebrovascular duplex?
So as I mentioned in my presentation, CT angio is better than CT with no contrast, because you can assess the extracranial and intracranial pathology, so which can make you help for the prognosis of the patient. And also I mentioned that the MRI, it's more benefit and more accurate than CT. So MRI actually with DWI sequence, it's preferable to do it in the patient with TIA. Yes.
Yes. We have another question. Also, you mentioned that the patient, if he has symptomatic carotid stenosis, 50% is recommended for stenting in the first 2 weeks. And regarding the guidelines of vascular surgery, they said this is after 2 weeks. So is it contradictory or this is another issue?
For the carotid, you mean? Revascularization?
Yes, for carotid revascularization.
I mean, all the data show that better to be within the first 2 weeks to have a better outcome for the carotid stenosis. So that's as far as I know so far, plus statin as well. So I don't know from vascular perspective if they have something different.
Okay, thank you, Dr. Megan. Mr. Ali, could we share Dr. Ahmed Al-Basyouni presentation, or still we have such technical problem? Mr. Ali?
1 minute, inshallah, and only second, inshallah, and we'll share it.
Okay, so you got the presentation?
Yes, I receive it now.
Okay, thank you so much. I have a question also from Egypt to Dr. Hani Arif. Few weeks ago, there was a declaration of Egyptian Genome Project. That Egyptian Genome Project could help in a stroke map, or just this is basic genome and we couldn't use it in stroke care and detailing specific policies for the future prevention of stroke?
I don't have much information actually about this project. I didn't discuss, but of course there is a concern about specific genetic problems in the Egyptians, especially with the neurodegenerative disorders, and probably heard, of course, the issue of the muscle diseases, for example. We are trying also to make a screening for those patients, either through their routine genetic analysis, or going through the whole genome, which is, very costly, and sometimes it's the only solution to find if there is a genetic link to a specific disease or not. But as I just mentioned, we are lucky because according to the grant we already had, part of this grant is dedicated to do a whole exome for a number of patients with a small vessel disease. And I guess we can get very important data from this analysis. Of course, it's quite costly to do for a single patient a whole exome or a whole genome.
Could we see in the future that a small vessel disease, yes, it is vascular pathology, could it overlap with the degenerative brain disease?
Definitely. I'm convinced. I like this slide I presented, which is the 3 trees: the neurodegeneration, the vascular component, and the inflammation. Definitely, I'm totally convinced that all our neurological disorders, they are having the 3 components with different degrees. Every time now you will come across, for example, even in multiple sclerosis, you will find maybe a little component of a vascular component. Of course, predominantly inflammatory and neurodegenerative. And the same applies for even some of the diseases which you couldn't imagine there will be inflammatory vascular component, like Parkinson or other diseases. So there is you cannot separate the 3 components from each other, because there is definitely interplay between the 3.
Okay, thank you, Dr. Hani. I have a question from another participant, a patient with for Dr. Magid. A patient well-known atrial fibrillation. He is in warfarin, and his last INR 1 week before transient ischemic attack, it was 2.2, and then has transient ischemic attack and did serum INR. It was 2.3. How can such a patient, if he is well committed to anticoagulation and this is reflecting on his bleeding profile, have TIA? Could the patient have TIA even his INR more than 2? And what we do at that time? Will we modify the dose of warfarin or keep the patient on the same dose?
Dr. Mohammed, hello?
Yes, Dr. Magid, do you hear my question?
Hello?
Yes. Did you hear my question? Dr. Magid? Dr. Magid? Dr. Magid? Hello, Dr. Magid, did you hear my question?
No. Sorry, my net was down, so I didn't hear anything. So it's actually it's come and go. So maybe it will go down in any time.
Okay.
Hello?
So, yes, Dr. Magid, we have a question for you.
Okay.
Okay. A patient with transient ischemic attack, he is well-known atrial fibrillation on warfarin. He had transient ischemic attack and his INR 2.2, and the asking question asks, how can he have transient ischemic attack even he is well anticoagulated with warfarin? And what will we do at that time? Will we stay in the same dose of warfarin or not?
So basically, in this type of patient, you need to look for sometimes for other etiology. The patient might have other etiology for his recent stroke. So you need to do an echo to look for something else making the patient having a stroke. This is one. The second thing, in this like kind of patient, usually if the target was initially between 2 to between 2.25, usually we increase the target between 2.5 to 3. So if the patient not responding to that, sometimes we increase the target up to 3.2 in sometimes. Also, sometimes you can add some other agent plus aspirin. You know, it's a very complicated case, but usually take it case by case.
Okay, so do you think Dr. Magid, he may has another etiology? Or you think he may has another etiology and may add another anti-ischemic measure to the warfarin? Is it right?
So yes, I mean, yes. So usually, yes, in this kind of patient, even if the patient he's, for example, taking dual antiplatelet, you need sometimes to look if the patient having some other etiology. For example, if the patient in dual antiplatelet and he's having a stroke, the patient might have atrial fibrillation, which is undiscovered by his first ECG or Holter monitor. So it's good to re-examine that again. So in this case, increase the target, the goal between for the INR, for example, make it higher for him. So the maybe problem the patient may be having some other coagulation issue while affecting the warfarin. Yeah.
Okay, thank you, Dr. Magid. Dr. Hani, do you want to add?
Yes, probably. I totally agree with Dr. Magid. You should go for another, maybe not uncommon, but another pathology with full anticoagulation can develop a stroke. Probably this patient might have a dissection, might have a thrombus, which is showering. You know, sometimes I had a case like this after giving a thrombolysis. We found that the patient is having total occlusion of the one of the major arteries in the lower limb, and he was about to be amputated, and we discovered that he's having a thrombus which started to fragment after the thrombolytic therapy. So probably those patients will need more detailed studies like echo, like studying of the vessel wall and so on.
Thank you, Dr. Hani. Really, I am interested with that discussion of such questions from both of you.
Dr. Muhammad, I think,
Hani,
Dr.
Dr.
Muhammad,
Megan. Yes, Mr. Alea.
I think we are facing some problems in this presentation. So I don't know what's the situation now.
Okay, no problem. We can end our presentation for today. We have still remaining 2 days, and we can add Dr. Ahmed Bassiouni presentation to any of the resting 2 days according to the schedule. And we have already discussed the questions and answers with our 2 outstanding speakers, Professor Dr. Hani and Professor Dr. Megan, and we can solve that technical problem in the next day of webinar. So for our audience, you can stay tuned. Our program and schedule is the same, and the presentation regarding endovascular intervention in acute ischemic stroke by Professor Dr. Ahmed Bassiouni will be added to either 2 days. Keep updated and follow us, and we will update you with that presentation.
Any more question, Mohammed?
No more questions, Dr. Hani. No more questions for Dr. Megan. And I was really honored to host you in that webinar. Professor Dr. Hani always joining us in our scientific activity in Saudi German Hospital, and also presenting a lot of scientific activities in different areas as a message for him, as we expect from him all the time. And also Dr. Magid, he has outstanding career in the stroke field. And we hope to host you, Dr. Hani, once again in Saudi German Hospital scientific activities. And I think our future activities, it will be live. Everything is going and pointing that everything will be okay in the future. Hope to host you again in Saudi German Hospital scientific activity and in Madinah in our live activities, not so virtual. And also expecting more sharing from Dr. Magid in our activities.
Inshallah.
Inshallah. Thank you, Dr. Hani. Thank you, Dr. Megan.
Okay. Bye, everybody.
Thank you. And goodbye. Thank you. Thanks to all our audience, and we apologize for that unexpected technical error. But our program is 3 days, so we can join and catch our presentation in the next day's schedule. Thank you for your valuable attendance, and again, apologizing for technical error. Thank you so much.
Thank you, Dr. Muhammad, for moderating this session, and inshallah we'll meet you tomorrow with the other speakers, and inshallah we'll have Dr. Ahmed with us, inshallah. Thank you all.
Inshallah. Thank you. Thank you. Thank you, Mr. Ali. Thank you.
Assalamu alaikum.
We can end it for